In this video, we're going to cover psychotic disorders. This will be helpful for you if you're in school or you're a healthcare provider and you're trying to get a better understanding of these disorders. We'll discuss how these disorders happen, who they happen in, how to diagnose them, the treatment, and how people with these disorders do long term. The psychotic disorders we're going to cover in this video are brief psychotic disorder, form disorder, schizophrenia, schizoaffective disorder, and delusional disorder. The key to diagnosing these is in the time frame a lot of the time. Brief psychotic disorder, for example, is less than 1 month of time frame of having psychosis. Form disorder is from 1 month to 6 months, and schizophrenia, you need at least 6 months of psychosis plus a prodrome, so the prodrome could be 5 months worth. Schizoaffective disorder is a bit different. It's where you have schizophrenia and a mood disorder as well. And delusional disorder stands on its own, in which patients only have delusions. Let's first go over the differential diagnosis of psychotic disorders. There's psychiatric differential diagnosis, there's a medical one, and then there's a substance-induced one. We'll start with the psychiatric. So there's schizophreniform, we talked about that one, 1 to 6 months. Schizoaffective, mood disorder plus schizophrenia. Delusional disorder, you only have delusions. Schizotypal personality, this is a personality disorder where they have strange beliefs, often they're paranoid, or they have, that should say odd, not off, odd or magical beliefs. They're eccentric, they don't have many friends, they have a lot of social anxiety. However, they have no psychosis. With these personality disorders, you don't have any psychosis, schizotypal or schizoid. So with schizoid personality, they have lots of social isolation, they don't enjoy social activities, and they keep to themselves. Again, no psychosis. Pervasive developmental disorder, so a developmental problem like autism. Malingering or factitious disorder. Malingering is where you're trying to get a certain gain. Maybe you want to stay in the hospital for free. And factitious disorder, these people want you to either feel sorry for them or they want some type of psychological benefit from it. Then the medical differential diagnosis is psychosis due to a medical condition. There are a lot of medical conditions that can cause psychosis. We're only going to cover a few of them here. This is not an exhaustive list because there are a lot. So some include Alzheimer's disease, a brain tumor, epilepsy specifically temporal lobe epilepsy can cause specific hallucinations, olfactory hallucinations, where you smell things that aren't actually there. So if a patient has that, you might want to send them to a neurologist. Subarachnoid hemorrhage, so a brain bleed. HIV, which is an infection. Hyponatremia, so low sodium. Hyperthyroid, so both high and low thyroid can both cause psychosis. B12 and folate deficiency, so vitamin deficiency. Steroids, both corticosteroids and anabolic steroids can cause psychosis. And mercury poisoning, there were a few other ones as well. Then there's substance-induced psychotic disorder, and that is if you take anything that then causes you to have psychosis. So that could be cocaine, marijuana, amphetamines, but it could be medications as well. The first one we're going to start with is brief psychotic disorder. So the etiology, why does this happen? We don't know why it happens. It often happens in extreme stress. So when people are very, very stressed, they're going through a tough time, that's when it seems to happen a lot more frequently. Who does this happen in? It's relatively uncommon. It happens in 0.05 to 2% of the population. That's the epidemiology. What are the signs and symptoms? So you need to have at least one psychotic symptom. So a psychotic symptom is either hallucinations, delusions, disorganized speech, or disorganized behavior, or catatonia. Catatonia is similar to disorganized behavior. A lot of the symptoms in catatonia are disorganized behavior, so that's why that's kind of grouped together. In this video, we're gonna split up all of these psychotic symptoms. We're gonna go over each in depth, and so if we don't go over it in depth right now, don't worry. By the end of this video, we're gonna have gone over everything. So here, we're gonna go specifically into disorganized speech and disorganized or behavior or catatonia. So let's start with disorganized speech. It's not linear or logical, and it doesn't make a lot of sense. So normally when you ask someone a question, they'll just respond linearly and logically, and they'll answer your question. So here are some psychiatric terms to describe people who do not have a linear and logical form of speech. There are two clusters that we can cluster a lot of these into. The first big cluster is looseness of association, which is its own thing as well, but we're going to cluster it in there. And then there's another cluster called a velocity cluster. Let's start with the looseness of association cluster. So your thoughts are not associated that tightly together, like maybe one part of the sentence is here, one part is over here. We'll go over all of these individually. So let's start with circumstantiality. And this is from least severe to most severe. So the least severe form is circumstantiality. You can imagine it like a circle. Someone goes off on a tangent, right? So they were speaking, they go off on a tangent. However, at the end, they come back and they connect the circle at the end. So they might talk about a lot of other stuff that isn't really relevant. A lot of storytellers will do that. They'll have a bunch of extra detail. That's what circumstantiality is. Lots of extra detail, but eventually they get to the point. Next is tangentiality. You ever heard someone say they went off on a tangent? Going off on a tangent means you were talking about what you were talking about, and then someone went off on a tangent and they never came back and answered your question. So that's what tangential is. You can just think of it as going off on a tangent. They'll never come back and answer your question. You can wait as long as you want. Looseness of association and word salad. Now, these are different. Looseness of association means the connectiveness between two sentences doesn't make sense. So one sentence, a full sentence with a period, that makes sense by itself. However, this sentence to this sentence doesn't make sense. The connection doesn't make any sense. That's looseness of association, okay? It's also known as derailment or disjointed speech. Same thing. Now, word salad is where the connection between words makes no sense. That's really severe. You probably see that in dementia more. Looseness of association, you can see that in schizophrenia. Now, the velocity cluster, on the way extreme side, there's mutism, so they're not speaking at all. Then there's poverty of speech and thought. That's the same thing. Poverty of thought, poverty of speech, same thing. You might see that written in different places. That's where people answer really short. They just give the minimum required number of words to answer your question. You'd be like, how are you doing today? Good. Do you need anything? No. They'll just answer really, really short. Even if they do answer in a few word sentences, it's short. It's a little bit too much to the point. They're really not adding anything additional. You can see that a lot of times in schizophrenia. Thought blocking, you also see this in schizophrenia. Someone will just be talking and then they'll stop talking, not just like a normal pause like you might do, like many of us do. We make normal pauses, we have to think. Thought blocking is where you think for maybe 20, 30 seconds, not normal, okay? You're just speaking and then you just stop talking abruptly. So that's abnormal. You see that in schizophrenia. Poverty of content is different from poverty of speech. Poverty of speech and thought means you're not speaking very much, short words, short sentences. Poverty of content means you could be speaking a lot. You could be saying tons and tons, but the content in there isn't really answering your question. They're just saying a bunch of words, but at the end of it, you're like, huh? I didn't actually get anything answered. The difference between poverty of content, you might be wondering, and tangentiality. What's the difference between those? Well, tangentiality, we're talking about one topic, and then the person who's tangential goes off on a tangent and start talking about a different topic. Now, poverty of content is where the person stays on the topic, but just doesn't answer the question. Now, pressured speech is often seen in mania, and that's where someone is speaking really, really fast because their thoughts are going super fast. If your thoughts are going super fast and you try to put it into words because you're manic, you're gonna have pressured speech. Now let's move on to disorganized behavior and catatonia. That's where they have severely bad hygiene or strange clothing or strange appearance. This is something you see. Unprovoked outbursts of laughter or emotion. So you might be talking about something sad and they just break out laughing. That's abnormal. Unprovoked outbursts of hyperactive, agitated, or violent behavior. Inappropriate social behaviors. So maybe some abnormal or inappropriate sexual behavior. Echopraxia or motor perseverations. So echopraxia is where you imitate someone else's movements. So if you are seeing a patient with schizophrenia and they're imitating your movements, like you go to pick up a glass of water and they imitate that, that's echopraxia. Now, how do you diagnose this? Well, you need at least one psychotic symptom. So pick one. Delusions, hallucinations, disorganized speech, or grossly or catatonic behavior. If they have one of those, that's it. That's all you need. It's got to be present for at least a day, but less than a month. If it's more than a month, it's schizophreniform disorder, remember? And these people with brief psychotic disorder, they return to pre-morbid functioning. With schizophrenia, a big part of it is that every time they have psychosis, afterwards they get worse. And they don't return to their previous functioning, their pre-morbid functioning. So how they were doing before they got psychotic, these brief psychotic disorder patients, they should get a full return. They should be back to normal, back to their usual self, okay? It has to not only be with a mood only or a substance or a medical condition. So if it's a medical condition, that's psychosis due to a medical disorder. If it's substance-induced psychosis, that's where someone did some kind of drug and now they have psychosis, that's different. That's a different diagnosis. And if it's only with the mood, So someone can have psychosis if they're depressed or if they're manic, right? Bipolar disorder. If they only have the psychosis during those mood episodes, and then when the mood episode is gone, they're no longer depressed, they don't have the psychosis anymore. That's not brief psychotic disorder. That's the mood disorder, for example, depression with psychotic features. So that's different. And then there are subtypes. We need to put these subtypes in. So is it with a marked stressor? Were they really stressed before this happens? Remember this, that's most of the time when this brief psychotic disorder happens is when people are very stressed. Is it without a marked stressor? Is it with a postpartum onset, which is within 4 weeks of delivery? What's the treatment for this? The treatment for a lot of these psychotic disorders is going to be very similar. Okay, so we're going to see a lot of this stuff. Again, the main form of treatment is a second generation antipsychotic. You can also use a benzodiazepine medication, like Ativan or clonazepam, and that can be used as an adjunct. So in addition to the second generation antipsychotic, normally the benzos are added, the benzodiazepines, if there's a lot of agitation, usually in the inpatient setting, or if the patient just can't relax. So first line treatment, aripiprazole or risperidone are great options. Any second generation antipsychotic has antipsychotic properties, and so it can be used. But these are two great options. First line for agitation, olanzapine and haloperidol, both very sedating. That's why those are indicated. First line for agitation, olanzapine and haloperidol, both of those are pretty sedating and they work well for aggression. That's why those are indicated first line for agitation. First line for insomnia. Due to underlying psychosis, we want quetiapine. It's oftentimes used for sleep. That can help people sleep. First line, if a patient has diabetes, obesity, or dyslipidemia, so their lipids are too high, they're overweight, they got diabetes, or they have uncontrolled cardiovascular risks. We want to give them antipsychotic medication that doesn't cause a lot of weight gain. These are great options here. Aripiprazole, ziprasidone, pimavanserin, lumateperone, all of those are great. There are a few others as well. How often do you want to follow up with these people with the brief psychotic disorder? Well, you need to see them at least weekly. If you're in the outpatient setting. After 3 months, they can follow up monthly, but you gotta see them frequently. This is pretty severe having a psychosis there. What's the duration of treatment? So how long do you have to treat these people for? You wanna treat with an antipsychotic for actually only 1 to 3 months. It doesn't sound like that long, but remember, these people are having this brief psychotic disorder and then they get back to their premorbid level of functioning. They get back to normal. So we actually don't need to treat that long in this case. 1 to 3 months, if it gets rid of their psychotic symptoms completely, okay? You treat with an antipsychotic, they get back to normal, and then you can treat them for only 1 to 3 months. If they don't get back to normal, that's a different story. You will need to treat a lot longer, if not indefinitely. So what's the prognosis with brief psychotic disorder? How do these patients do long term? Unfortunately, the psychotic symptoms seem to come back often. Some good prognostic indicators, meaning these patients will most likely do better if they have these things. They were doing really well premorbidly. Okay, so before they had this psychosis, they were doing well in their job, in their social life, in their family life. They don't have a lot of premorbid schizoid traits, so they don't stay to themselves a lot. They're not super anxious socially. If they have severe precipitating stressors, so remember, this happens in people who are very, very stressed before this psychosis. So if they have that, that's good. That's normal. That's expected because most of the time this happens in people who are very stressed. If they didn't have a lot of severe precipitating stressors, then we're a bit more worried that they might have something like schizophrenia. Is it a sudden onset of symptoms? That's a good prognostic indicator. It happened really fast. It came on fast. Remember, schizophrenia, you have a long prodrome where people start declining in their social functioning, their work functioning, their mental capacity just starts going down. So if this happens fast and they don't have all that lingering stuff for months coming on, it's a good prognostic indicator. If they have affective symptoms, emotions are good here. If they're emotionally flat, that's a bad sign. If they're confusion or perplexed during the psychosis, that's a good sign, probably because it indicates more delirium. They have little affective blunting. Again, we already talked about that. Emotion, no emotion is bad, emotions are good. Short duration of symptoms, the shorter they have these psychosis, the better. And they have no schizophrenic relatives. So all of these are really good prognostic indicators that these people are going to do well. Let's move on to schizophreniform disorder. Remember, 1 to 6 months of duration of this psychosis. So it's in the middle of brief psychotic disorder and schizophrenia. So you got brief psychotic disorder, schizophrenia, got schizophreniform right here. What's the etiology? Why does it happen? Same as schizophrenia. We're going to cover that in depth when we get to schizophrenia next. So hold off on that. How often does this happen? Well, it's half as common as schizophrenia. we'll see that schizophrenia happens in 0.7% of the population. It's rare, less than 1%. This schizophreniform, even more rare, 0.35%. So what are the signs and symptoms? Well, the same as schizophrenia, but it usually comes on fast and does not have a long prodromal phase, unlike with schizophrenia. So it doesn't usually drag on and have that long, month-long prodromal phase where people decline in function. Usually, it still can. So you need either delusions, hallucinations, speech disorganization, behavior disorganization, or negative symptoms. Again, we're gonna go over all of these. So this slide, we're gonna go over hallucinations. So visual and auditory are the most common. If a patient is having tactile, meaning they're feeling stuff that isn't there, maybe they feel like bugs crawling on them, or olfactory, they're smelling things that aren't there, other people can't smell this. They need a medical or a neurologic workup because those are more rare. What are some examples of auditory hallucinations? You can have voices commenting on what you're doing. Voices can be conversing. Maybe there's two voices and they're talking amongst each other. The voices are often critical of the patient. They tell them that they don't do well or they're not doing good enough. There can be command hallucinations where the voices tell the person what to do, tell them, do this thing. However, most of the time, people with schizophrenia, people with schizophreniform, they can resist these voices. They don't have to do what the command hallucinations tell them to do. So that's good to know when we're talking about factitious disorder, when we're talking about malingering. If a patient says they have command hallucinations and they have to do whatever the voices tell them, that's a red flag. The voices are usually intermittent. They're not going 24/7. They come and go. It comes from outside the head. The voices aren't in your head. So you can ask the patient, where does it sound like these voices are coming from? Does it sound like they're coming from inside your head, or does it sound like they're coming from outside? Patients will say it sounds like it's coming from the outside. The voices are clear, they're not muffled. Again, if voices are very muffled, the patient says, or it's coming from inside their head, red flags, we think about malingering, factitious disorder. Delusions are almost always present with auditory hallucinations. Interesting to know. There's somatic and tactile, olfactory, and visual. So how do you diagnose schizophreniform disorder? Again, it's the same as schizophrenia except the time frame. The time frame is the only difference here. It needs to be less than 6 months duration. It needs to be at least 1 month. Remember, if it's less than 1 month, that's a brief psychotic disorder. So you need 2 symptoms for schizophreniform and schizophrenia. So 2 symptoms for at least a month, and then you can have up to 5, well, we should say up to 4, right? If it's 6 months total, that's schizophrenia, okay? So just remember that. But let's go with it here, plus 5 months of prodrome or residual symptoms. Delusions, hallucinations, speech disorganization, behavior disorganization, negative symptoms. At least one of these need to be the big 3. Delusions, hallucinations, or speech disorganization. So if someone has negative symptoms, we'll go over these as well, okay? Negative symptoms can be low motivation or little pleasure in doing things. And then behavior disorganization. So if a patient is like stuck in a certain position, they have waxy flexibility. If they only have those 2, that's not schizophreniform. That's not schizophrenia either. That's something else. We can't diagnose that, okay? So they need at least 1 to be delusions, hallucinations, or speech disorganization. So what's the treatment here? Same as for schizophrenia, same as for brief psychotic disorder. We want a 2nd-generation antipsychotic. These are all great options. You could also use a 1st-generation antipsychotic. We normally don't pick those because they have higher incidence of extrapyramidal symptoms, so people can get drug-induced Parkinsonism, they can get akathisia, where they feel really restless and they feel like bugs are crawling on them. What's the prognosis? How do these patients do long-term? And with schizophreniform disorder, 60 to 80% will later develop schizophrenia. So schizophreniform disorder, it's not good. Things aren't looking good with schizophreniform disorder. But remember, they're having this psychosis and or with residual symptoms or the prodrome for 6 months. It's a long time. It's not like brief psychotic disorder. Brief psychotic disorder is 1/6 the amount of time. So it's different. The prognosis is worse, but you gotta remember, it's a long time, up to 6 months. The remaining people will have recurrence of this and few will only have 1 episode like this. So it's very rare for someone to just have 1 episode of almost 6 months of psychosis. It's pretty rare. Okay, let's talk about schizophrenia. So why does this happen? Well, we don't know 100% for sure. There's 3 well-accepted current theories on schizophrenia, and we're going to go over each one briefly because they go very in-depth. The dopamine hypothesis. So there's an integrative hub, mesostriatal hypodopaminergia. That's the new theory. We're going to go over that. There's glutamate hypothesis, which is NMDA receptor hypofunction, and serotonin hypothesis, which is 5-HT2A receptor hyperfunction increased in the cortex. 5-HT just means serotonin, so you can say serotonin 2A. Let's go over the first one. So the dopamine hypothesis. The old dopamine hypothesis said there was, and we're going to have a picture as well. So if you're visual, just wait until the next slide. We're going to go over it. The old dopamine hypothesis was that dopamine was too high in the mesolimbic pathway, which goes from the ventral tegmental area to the nucleus accumbens. Let's go to the next picture. Have a look here. So the ventral tegmental area to the nucleus accumbens is the purple one there. That's the mesolimbic. You see that one there? That was the old dopamine hypothesis on how schizophrenia happened. Let's not spend too much time on that one. The new dopamine hypothesis, the one we actually want to know now, is that dopamine is too high in the integrative hub mesostriatal hypodopaminergia. The integrative hub basically, it's very similar to the old hypothesis. The only difference is the integrative hub means it's the substantia nigra, which is the ventral striatum, same thing. If you see those two things written, they mean the same thing because they're in the same area. Plus the ventral tegmental area. Let's go have a look at that real quick in the picture. So if you see in this picture, the substantia nigra plus the tegmentum. The tegmentum is the ventral tegmental area, the VTA. Same thing. So the old hypothesis, old dopamine hypothesis said the pathway that's in purple was too excited and therefore it was too activated, and then when we come to the end of the purple pathway, the nucleus accumbens, which is where dopamine is released, was releasing too much dopamine. Boom, you get psychosis. That was the old theory. Now, the new theory, very similar, very similar. However, this integrative hub is both the substantia nigra and the tegmentum. So if you look on the picture there, you see substantia nigra, you see tegmentum. Tegmentum, VTA, ventral tegmental area, same thing. You can think of this new hypothesis, this integrative hub, as both of those. So it's no longer just from the tegmentum to the nucleus accumbens. Now it's both of those, because on PET scans, when they were looking at schizophrenic people or people who had psychosis, on the new PET scans, where they look at activity in the brain while people are actively psychotic, they couldn't tell the difference between the substantia nigra and the tegmentum because it's too close together. So that's why this new theory says, it's no longer just the VTA, it might be the substantia nigra too. Let's just lump them together and call it the integrative hub. And down there where the substantia nigra is in the tegmentum, that's the meso area, so let's just call it meso. And striatal, well, you see at the end of the purple arrow, you see the striatum there, so the whole thing's a striatum, and the nucleus accumbens is just on the bottom. So they call it just, we'll just call it meso for the bottom, and then striatum for the top. And there's too much dopamine, so hypodopaminergia. Okay, simple. That's the dopamine hypothesis, the new one. So if someone says, they're talking about the dopamine hypothesis and they say the mesolimbic pathway, they were correct, but there's a new theory now, okay? And the new theory is the integrative hub mesostriatal hypodopaminergia. That's a new theory. You've seen it in the picture here. Let's move on. Let's go on to number 2, the glutamate hypothesis. So, NMDA receptor hypofunction. So, this is where from the ventral tegmental area to the nucleus accumbens, it gets overactive, same as the dopamine hypothesis. Remember? Let's go look at the picture here. See the tegmentum there? That's the VTA, the ventral tegmental area, and the nucleus accumbens, purple. That pathway is always getting hyperactive. That's the psychotic pathway. But now, what's this NMDA receptor hypofunction? Well, they're saying, okay, maybe it's not just happening randomly right there from the VTA to the nucleus accumbens. It's actually happening higher up in the cortex with these NMDA receptors. These NMDA receptors are too low, they're not working right, and then it comes down to the VTA and then it gets too hot. So what are we talking about here specifically? Well, there's a problem with the NMDA receptor on the GABA neurons in the cortex. Okay, let's look at the picture here. There's a problem with the GABA neurons in the cortex. Well, the cortex, if you look at the picture here, you see where the green lines are and where they end, where it says DLPFC, the dorsolateral prefrontal cortex, where it says VMPFC, the ventromedial prefrontal cortex. So you see that's the outer part of the brain, that's the cortex. And so what they're talking about here with this NMDA receptor hypofunction is they're saying these GABA neurons are not getting activated properly in the cortex. There's a problem with them. GABA is an inhibitory neurotransmitter. When GABA is released, it slows down the glutamate. Glutamate's excitatory. Glutamate means go, go. GABA means hold up. So if GABA is not being released, telling them to stop, then it's going to be going too fast. So you can see how in the cortex, in the outer part of the brain, there's these NMDA glutamate receptors. Well, on GABA, well, they're not getting GABA activated, so GABA's not being released. So then there's a pathway that travels down from the cortex to the tegmentum. You see in the picture of the tegmentum. And if GABA is not coming down all that way, then the tegmentum gets overactivated, and this pathway from the mesolimbic pathway, I know we talked about the integrative hub, that was the dopamine hypothesis. With these other two hypotheses, it's always the mesolimbic. So this mesolimbic pathway gets overactivated because GABA's not slowing it down. That's the theory. There's a bit more writing there. We basically went over it though. And at the same time, there's too little dopamine released in the prefrontal cortex, so you get negative symptoms. Let's look at the picture here. So look at the green pathway. That's the mesocortical pathway. That's the pathway that's decreased, has low dopamine. If you have low dopamine in the prefrontal cortex and the ventromedial prefrontal cortex, you'll get negative symptoms. You'll get avolition, no motivation. You'll get anhedonia. You don't want to do anything. These are the negative symptoms in schizophrenia. We're going to go over every single one of the negative symptoms later on though. And let's round it off here. The last hypothesis, the serotonin hypothesis. 5-HT, remember, it means serotonin. So serotonin 2A receptor hyperfunction in the cortex. So the cortex, remember we talked about this, it's the outer part of the brain there. The serotonin receptors are too active in the cortex? Okay, so why does that matter? Well, there's glutamate pyramidal neurons in the prefrontal cortex, and these get overstimulated by overactivation of the 5-HT2A receptors. So glutamate neurons, remember, glutamate is excitatory. Glutamate means go. They have these serotonin neurotransmitters on them. For some reason, there's many reasons. There can be dementia. These serotonin receptors can get drug-induced, like compounds that really activate serotonin, like LSD or psilocybin. Those can really stimulate these glutamate receptors. And then you get psychosis. How? Glutamate receptor gets overexcited. And there's a pathway that goes from the cortex, which is the outer part of the brain, all the way down again to, guess where? The tegmentum. And then what pathway gets overstimulated? Well, you already know. It's the mesolimbic, the purple, going from the tegmentum to the nucleus accumbens, of course. So here it's written, the same pathway as the glutamate hypothesis. Mesolimbic is overactive. That's why most antipsychotics block 5-HT2A. We're gonna go over a video. Our next video is gonna be all about antipsychotic medications, and you'll see almost every second generation antipsychotic blocks 5-HT2A. And that's probably where they got this hypothesis from. They're like, hey, we block 5-HT2A, it works for psychosis, probably where this theory came from. Okay, well that's the three. So schizophrenia, who does this happen in? It happens in 0.7% of the world. We talked about that earlier. Happens in both sexes equally. The onset's a bit earlier for men, 10 years old to 25 years old. For women, it's a bit later, 25 to 35. Women also have a bimodal distribution. A small percentage of them, 3 to 10% of women, will have onset after 40. For men, that would be a bit more unusual. Now, if you have onset earlier than 10 years old or later than 60, very rare. So if someone's coming with psychosis, they're older than 60 or they're less than 10, you gotta be real careful about making a diagnosis like that. Super rare. Here's some risk factors. Being born in a big city increases the risk of schizophrenia. The bigger the city, the bigger the risk. Not really clear why that happens, but it's known. Heavy cannabis use increases the risk of schizophrenia by as much as 40%. This is a big risk, and it's even more risky when marijuana is smoked during childhood or adolescence, when they're teenagers. Because in adolescence, the wiring, there's already, in the brain, the wiring's already done. There's as much wiring as there's going to be. However, in adolescence, the wiring changes formation. You get rewiring of neurons in the brain during teenage years. And so smoking this cannabis, especially in the teenage years, can mess up with that rewiring. We don't know why there's problems with the rewiring. Some people get bad rewiring in the teenage years and they get schizophrenia, and other people don't. We don't know why. So you definitely don't want to smoke any marijuana, do any marijuana during your teenage years. The higher the THC content in the marijuana, or if you're doing the synthetic marijuana, which has super high THC content, doesn't have a lot of CBD, even bigger risk of developing a psychotic disorder. The higher the THC, the more risk. When it's balanced with the CBD, CBD is actually an antipsychotic compound, the lower the risk. So what are the signs and symptoms? Well, there's premorbid, and then there's a prodrome, and then there's the active psychosis. So the premorbid signs and symptoms appear before the prodromal state of the illness. The premorbid signs and symptoms, they look like schizoid and schizotypal personalities. So schizoid, they really keep to themselves. They have a lot of social anxiety. They don't like being with other people. That's just how they like it. Schizotypal, they have odd or magical beliefs. Maybe they think they're a wizard, something unusual like that. They like being quiet, passive, introverted. They don't have many friends as children. Now, the prodrome, this is part of the evolving disorder. So this is where they start going downhill functioning-wise. There's a nice definition here. The patient's ability to perform in society goes down before the first time they have psychosis. They stop socializing, they get irritated easily, their school and work suffer. They might get very hyper-focused on a new religion as well. Adolescents might have OCD behavior as a prodrome. That's an interesting one to remember. New poor functioning in occupational, social, or personal activities, so they're just not doing well in their work life, their family life, or their social life with friends. They might have markedly peculiar behavior, so really strange behavior. Abnormal affect, meaning they laugh when they're sad. They have unusual speech, bizarre ideas, and strange perceptual experiences. So what are the signs and symptoms? Well, we need either hallucinations, delusions, or speech disorganization. Remember, you need to have one of those. But you need two total. But one of them has to be those three. We're going to go over delusions on the next page. These are all the delusions. We got persecutory, so the patient thinks that someone's out to get them. Maybe they think the FBI's out to get them. Jealous. Normally, jealous delusions are, it's always that a partner is cheating on them. Guilt or sin, a delusional amount of guilt. They feel very, very guilty, more than someone else might. Most people have a normal amount of guilt. They do something bad, they feel guilty about it. A delusional amount is way over the top. It's at the end of the spectrum. Grandiose delusions is where they have a really heightened sense of self. Maybe they are going to run for president. You might think, well, that's normal. Why can't someone want to run for president? They might have never done anything political ever, and then the next day they know they're going to be president and they're working furiously on getting things done to become the president. Really unusual, not a normal conclusive jump. Religious, they get hyper-focused on a religion. Somatic delusion, there's illness anxiety disorder where people think they have a disease. There's somatic symptom disorder where people have symptoms and we don't know why it's the case, and it could be that they're either imagining the symptoms or they could just have the symptoms and we just don't know, we can't explain it medically, so we call that somatic symptom disorder. So what's somatic delusions? How's that different from somatic symptom disorder? Well, it's the extent to which someone believes it. If someone has a delusional thought that they have these somatic symptoms versus someone with somatic symptom disorder, they might be able to convince that, hey, maybe I don't have this. Or a somatic delusion might be that someone says, I'm empty inside, and they don't just mean they're sad, they actually mean they don't have any organs inside or something strange like that, okay? Delusions of reference, so that's where they see normal daytime activities happening and they think they're related to them. So maybe they think the newscaster is talking about them, or someone drives by and flashes their lights at someone else and they think they're sending them messages. Delusions of being controlled. That one's pretty self-explanatory. They think they're being controlled by something, probably aliens, or maybe they think the FBI is controlling them or the CIA. Usually it's something like that. Mind reading is where they think they can read other people's thoughts. And thought broadcasting is where they think they can transmit their thoughts to someone else telepathically. Thought insertion is where they think someone else or something has inserted ideas into their head, maybe aliens again, FBI, CIA, something like that. And thought withdrawal is where they have delusions that someone has extracted information from their head. So how do you diagnose this schizophrenia? Well, you need two of these psychotic symptoms. You need two of either delusions, hallucinations, speech disorganization, behavior disorganization, or negative symptoms. One of them has to be either delusions, hallucinations, or speech disorganization. And they need to have had this for these psychotic symptoms for at least a month, but they can have the prodromal or residual symptoms, so they're still not functioning at their full capacity for 5+ months. If we go back to the prodromal, let's have a look here. So remember the prodrome, they're declining in functioning, they're not doing well socially. Maybe they have really unusual new religious ideas or abstract ideas, new philosophy, they have these strange headaches, back pain, weakness. It's a difficult diagnosis to make. Maybe they have unknown strange behavior, strange speech, bizarre ideas. So what's the treatment for schizophrenia? Same as schizophreniform and brief psychotic disorder, we want a second-generation antipsychotic. Interesting to note, cariprazine has shown to be extra helpful in negative symptoms. And we're gonna go over cariprazine in depth in the antipsychotic treatment video. So stay tuned for that. Of course, you can use the first-generation antipsychotic. I put haloperidol there. They're just not used very often. Of course, there's other ones that are used as well, like fluphenazine and loxapine, but really we don't use those that much. Now, when we're talking about relapses, 16 to 26% of patients receiving treatment, so they're getting treated with a second-generation antipsychotic, will get a relapse in a year. So it'll happen again, they'll get the psychosis again. No problem, then we help them, we treat them. So less than a quarter. Now, 53 to 72% will relapse without medication. So if you don't get treated for this, that's really not in your best interest if you have schizophrenia, because up to a 75% chance of this psychosis coming back versus a 25% chance. So it's a 50% difference. You definitely want to treat with this. So how long do you need to treat for? Well, if it's the first episode of psychosis, we continue it for at least a year, right? The symptoms go away completely. We treat with an antipsychotic. Symptoms go away completely, treat for at least a year, and then we'll see. Maybe we could discontinue. Maybe we could stop the medication. Is it the second episode of psychosis? You want to treat this forever. They only get one try with this. One episode of psychosis, you treat for a year, you come off it, and it comes back, you treat forever. Why? Because you can get treatment-resistant schizophrenia, treatment-resistant psychosis if you don't treat this and it keeps coming back. Then it doesn't get treated well forever. So you really want to treat this forever after the second episode of psychosis. 40 to 50% of patients are non-compliant within 1 to 2 years. That's a problem, meaning they don't take their medication. Up to 50%, so half of patients don't. Half of schizophrenic patients don't want to take their medication for some reason. Now, what are some good ways to help them? Well, compliance usually is like they don't want to take the pill every day. It's not convenient, they don't want to do it. So there's long-acting injectables. We're going to talk about these in the antipsychotic video as well, antipsychotic medication video. We got fluphenazine, haloperidol, risperidone, paliperidone, aripiprazole, and olanzapine. They're all injectables, LAIs. Now, how do you tell if it's a good trial of an antipsychotic? You need to do it for at least 4 to 6 weeks. I've seen some sources just say 6 of an adequate dose of an antipsychotic. Okay, that's a good trial. And even if you get a little bit of a response, a mild response or improvement during that time, the 6 weeks, you can continue to improve for 3 to 6 months after that. So a little bit of improvement in 6 weeks is good. You want to keep going. If we're not having any improvement, you want to check blood levels. We're going to go over this in the antipsychotic video as well. I'm excited to go over that one. You want to check blood levels to make sure they're in a good range. There's certain ranges you want to use. Oh, you can also make sure the patient is actually taking the medication by checking a plasma level and making sure they're not a rapid metabolizer. If they're metabolizing the medication fast, meaning they're burning through it fast, then the medication is not staying in their bloodstream and it's not helping them. You also want to add psychotherapy, so therapy, for these schizophrenic patients, because patients who get medication plus therapy, they stay with the therapy, they take the medication longer, they have less negative symptoms, so they do better socially, and they have overall better functioning. You can do cognitive behavioral therapy, that's CBT. You can do art therapy, schizophrenic patients do well with that. Family-oriented therapy, so the family's in on the group. And then group therapy is where other people with schizophrenia would meet and have a therapy session together. All of those can be helpful. You might want to do one of those, or you might want to do 2, or you could potentially do all of them if it's reasonable. So how do schizophrenic patients do long-term? Unfortunately, they live as much as 20% shorter lives. It's not clear why that's the case. 20 to 30% of patients continue to experience moderate symptoms, about a third there, so okay, but not ideal. And then 40 to 60% of patients remain significantly impaired with their disorder for their entire lives. That's why a lot of patients with schizophrenia, they're on disability. They can't really function well despite treatment, or maybe they develop treatment resistance if they didn't take the medication, or sometimes it just happens. Remember, in 16 to 25% of patients, it can just happen where the psychosis comes back. So what are some good prognostic indicators, meaning which patients are more likely to do well? If it happens fast, acute onset, if there's a female sex, or if they live in a developed country. So if they live in the US, that's good. What's a bad likely outcome? If it happens slowly, so there's maybe a really long prodrome, if it happens when they're a child, if they have really bad premorbid functioning, so they just can't get any work done, they aren't thinking well, they're not doing well socially, not doing well in their home life. Okay, let's move on to schizoaffective disorder. So why does it happen? It's not clear why it happens. It's in the middle of a mood disorder and schizophrenia because you need to have both. And we'll go over that a bit more in the diagnosis part of it. How often does it happen? It happens half as common as schizophrenia, so 0.35% of the population. How do you make the diagnosis of schizoaffective? Well, you need to have schizophrenia. That's number one. So you need to diagnose that. And then number two, they also need to have a mood disorder. This mood disorder can either be a major depressive disorder or it can be a bipolar disorder, one or two. And you need to have both of these. So what are the signs and symptoms? Let's go over the negative symptoms here in depth. Again, schizoaffective, schizophreniform, and schizophrenia all have these negative symptoms. So you can get affective flattening or blunting. That's where people have unchanged facial expressions when they're talking, decreased spontaneous movements, maybe they don't move their hands at all, paucity of expressive gesture, right, hands. They don't have good eye contact, you can see that in autism too. Affective non-responsivity, similar to facial expressions, they don't move their face a lot. Inappropriate affect, maybe they laugh when they talk about something sad, that's inappropriate affect. And lack of vocal inflection, they speak in a very monotone, like a professor. Alogia, which is poverty of speech, they're just not speaking a lot. Poverty of content of speech, meaning they could speak a lot, but they're just not getting to the point. Blocking, they speak and then they stop talking for like 20 to 30 seconds, maybe longer. Increased latency of response, similar to blocking, but they just take long to respond, not quite as long as blocking though. Avolition and apathy. Avolition means they have no motivation to go do stuff. Apathy means you just don't care about anything. And then anhedonia means you don't get any pleasure in doing things. And asociality, you don't want to hang out with any friends. So let's go back to avolition and apathy. Their grooming and hygiene, not good. Impersistence at school and work, so at school and work they're doing poorly. Physical inertia, they got no energy. And then in anhedonia and asociality, their recreational interest and activities suffer, so they don't want to do any sports. They don't have any sexual interest in activities. Intimacy and closeness not doing well. Relationships with friends, they don't want to hang out with friends. Inattention, social inattentiveness, so they can't do well socially, and inattentiveness during testing, so they can't keep their focus when they're trying to learn things. So how do you diagnose this? Again, it's the same as schizophrenia. You need one of the three: hallucinations, delusions, disorganized speech. You need 2 total. But you also need a mood disorder. So the key to diagnosing this versus diagnosing schizophrenia, and occasionally they have a major depressive disorder, right? What's the difference? What's the difference between the schizoaffective, schizophrenia, and then they get depressed too, right? Is it schizoaffective? No, they're different. So with schizoaffective, most of the time they have the mood disorder. Most of the time they have major depression, or most of the time they have the bipolar. And then they also have schizophrenia sometimes. There's no set split, but we can just imagine maybe they have 80% mood disorder and 20% schizophrenia, right? However, they can't only have the psychosis during the mood episodes. If they're depressed and they have psychosis, that's depression with psychotic features, and same with the bipolar. That's mania with psychotic features. So they need to have it separately. But the key to differentiating that is that most of the time they have the mood disorder with schizoaffective. It's rare, the schizoaffective, so we really shouldn't diagnose it too often. What's the treatment? Same as psychosis. Benzos for agitation. First line for psychosis, continue treatment for a year. Second episode of psychosis, continue treatment indefinitely. We went over this tips. Antidepressants can be used for major depressive disorder or bipolar. You gotta be careful with bipolar. It can cause rapid cycling, so it can cause you to have mania if you give antidepressants without a mood stabilizer or an antipsychotic. Of course, you can give these antidepressants once the patient is stable on an antipsychotic medication. Yeah, you can also give mood stabilizers for bipolar disorder. We got lithium, carbamazepine, Depakote, they're all good. Also lamotrigine. How do schizoaffective patients do long term? Well, they'll have a bad outcome, same as schizophrenia, if they have these. And basically this is the same as schizophrenia. The only difference is on the bottom there. It says if they have a family history of schizophrenia, that's not a good prognostic indicator as well. All right, let's talk about delusional disorder. So why does it happen? There are some theories, but overall, we don't know why it happens. So we're not gonna speculate. How often does it happen? It's very rare, 0.03% prevalence. What are the signs and symptoms? Usually it's non-bizarre delusions. So people with schizophrenia can have bizarre delusions, like they think aliens, or a bizarre delusion is something that's not possible. Like there are aliens inserting thoughts into my head, right? Not possible. Non-bizarre delusions are things that could happen. Erotomanic means you think someone else is in love with you. It could be possible. Grandiose, like you think you're going to accomplish something that is way above what you could possibly accomplish. Could it happen? Okay, it could. Jealous, you think your partner's cheating on you. It could happen. Persecutory, you think someone's out to get you. Maybe you think the FBI's out to get you. Maybe they are. It could be. Somatic, meaning you have these delusions that something is happening to your body. You have these feelings. Maybe you have the delusional headache, somatic symptoms. That would be a somatic symptom. Sure, you could be having that. Mixed. So if you have more than one and one doesn't predominate the other, like one isn't way more than the other, you could just call this mixed. Or unspecified. Maybe it doesn't fit into any of these, and then you just call it unspecified. So how do you diagnose this? Well, they need at least to have one delusion, but otherwise they need to be doing well. That's a big key. Patients with delusional disorder, they do well. They have their jobs, they have friends, they do well in their family. They don't have the same social and occupational and cognitive problems that patients with schizophrenia have. So they need one delusion for 1 month. You want to specify which type and say whether it's bizarre or not. Can a patient with delusional disorder have a bizarre delusion? Yes, but it's less likely. Most of the time, delusional disorder, non-bizarre. What's the treatment? Well, antipsychotic. And you want to add on therapy as well. Cognitive behavioral therapy, CBT, and family therapy work best. Hopefully, the delusional patient will want to take medication. A lot of times they don't. So that's the tricky part. So how do these patients with delusional disorder do? Well, 50% recover fully. That's nice. About a third improve a lot with medication probably. And 20% have delusions forever. Unfortunately, they get treatment resistance. Even if they get medication, it's resistant. So that's a smaller percentage. So most of these people, 80%, they do well. So that's good. What's a better prognostic indicators? Well, if they have persecutory, they think someone's out to get them. Somatic, they have this bodily complaint that they feel. Or erotomanic, they think someone's in love with them. Those patients usually do better. The ones who do worse are the ones who are grandiose, like they think they're the Messiah, or they think they're the president, or jealous delusions, they think their partner's cheating. They don't do as well. Okay, so here's a summary of everything we went over today. Brief psychotic disorder. Remember, this psychosis needs to happen for less than a month. Schizophreniform, it happens between 1 and 6 months. Less than 6 months. Remember, if it's 6 months and above, it's schizophrenia. And with the schizophrenia or schizophreniform, you can include the psychosis, and you can also include the prodrome. And you add that time together to get the total. Schizoaffective, you need schizophrenia plus a mood disorder. And remember, the difference between schizoaffective and schizophrenia who just happens to have depression every once in a while or mania every once in a while. The difference is with schizoaffective, most of the time they have the mood disorder. And sometimes they have the psychosis. Delusional disorder, they only have delusions. And then there's 2 personality disorders here. We are not going to go over them today as much. We're going to go over that in the personality disorder video. But there's schizotypal, again, no psychosis. Schizoid, no psychosis. Here's the sources we used. Everything's on the pages and mentioned. I hope you enjoyed this video. Let me know in the comments what you'd like me to cover next or how you'd like me to do it differently. Thanks for watching.